So, just gonna click that. We are so excited to have you today as we talk about transforming the pediatric to adult healthcare transition in Minnesota. We welcome you to introduce yourself in the chat, tell us a little bit about where you're coming from and what you do. And wanted to give a big shout out to all of our sponsors there on the bottom of the screen. So Gillette Children's, the National GOT Transition program, Project ECHO, of course, the Minnesota Department of Health, where our funding comes from, and the Copic Medical Foundation in Colorado, where we have some additional funding from as well. The aim of us coming together and having these really invigorating chats is to transform Minnesota, and hopefully outside of Minnesota too, healthcare systems to provide equitable, accessible, and trauma-informed pediatric to adult healthcare transitions for all Minnesotans and all people. Like I said, we have amazing funders and support really across the US, which is fabulous. You will see and hear from some of our core faculty today. I'm Tori Barr. I'm a Med-Peds complex care doctor at Gillette Children's, where I do a lot of transition practice. And then we have representatives from GOT Transition, the Minnesota Department of Health, mHealth Fairview, and our lived experience expert as well. We also have a greater team that's even further behind the scenes, really steering the work. So we could not do this incredible work without all of the people on this screen. You can read all about them on our website. This is a CME activity. You should get all of the information you need in order to submit your CME to your respective boards through your email. And this is equal to 1 contact hour, so we want to make the most of the next 60 minutes. In order to really maximize this learning collaborative, we want to make it interactive. So we would invite you to turn on your video, mute unless you're speaking. If you want to ask a question, we welcome it at any time. So raise your hand, put a question in the chat. We'll be monitoring that. And then if you do come off, if you come on the screen to ask a question, just introduce yourself so we know who you are. Next. The structure of the ECHO session, I'm doing the intro right now. We'll have a brief didactic, then a exciting case, and then we'll wrap up and we'll go about our days wiser about how we can do transition better. We also would love to hear from you. We know that you have tough transition cases. So we want to help. So this is a great forum that you can present a case that you're struggling with of how can you do it better and get the perspective of many people across Minnesota, across the US, and across many different disciplines. It can be a case that is patient focused. So I have this patient who's struggling with this, or it can be a case that's focused on, I'm trying to do this transition work at my institution and I'm running into these barriers. We really know that transition is both helping patients, but then creating a system that is sustainable and can make this care better for everyone. Next. When we present cases, we're not actually establishing any relationships per the ECHO model. So with no further ado, I have the great pleasure to introduce Dr. Tisa Johnson-Hooper, who trained medical school here in the great state of Minnesota at the Mayo Clinic, then went to Boston for her residency and fellowship, and now is at Henry Ford Health in Detroit, Michigan. She is the medical director for the Center of Autism and Developmental Disabilities and has devoted a large part of her life to transforming transition. And we are so thrilled to be able to learn from her today. So welcome, Dr. Johnson-Hooper.
Thank you so much. And truly, it's my honor to be here, and I appreciate the invitation, the opportunity to speak about some of the work that I've done. Are you going to share the slides or?
Yep, I can if you would like, unless you wanted to yourself.
Well, you know what? Let me pull them up so that just want it to be whatever is seamless. Can you go ahead and just advance them? I think it'd be easier.
Yeah, sure.
I don't have my dual screen. I'm at work today, so sorry for the clunkiness. It'd be easier if you just go ahead and advance and we'll jump into this. You can go to the first.
Are you seeing them, everybody?
I am not seeing them. Actually, the next slide is off to the right. I don't know if everybody else sees it, but you haven't advanced yet.
I see the objectives.
It may be easier for me to. Okay. So I'm advancing this. Gotcha. Never mind. So yep, these are the objectives. Okay. In this time together, I hope to outline goals and action steps to ensure a safe transfer from pediatric to adult outpatient care for young adults. We'll identify challenges to ensure a safe transfer, and then identify tools that can help to improve transfer and integration into adult care. The outline today, we're just going to consider briefly some patients ready to transfer and integrate into adult practice. Briefly define terminology, highlighting the 6 core elements, but spend the bulk of the time really to detail tools and process changes for transfer and integration to adult practice. And then lastly, just explore necessary changes to the process so that we can achieve health equity. So as we progress through the slides, I just wanted you to consider these patients. They represent the population that we're talking about. These are patients experiencing the process and the process changes and tools that I'll discuss. First, the 17-year-old who's entering an out-of-state college. She comes in requesting her health appraisal form. There's a 20-year-old with persistent asthma, followed by family medicine, and a 21-year-old with autism and anxiety disorder, followed by pediatrics, accompanied by his parents for his well child or well adult visit at this point. So I'm just going to level set. I know folks, most everyone should be familiar with healthcare transition, but I want to make sure we're all talking the same language. So quickly, the definition of healthcare transition is knowing that healthcare transition is a process. It's a process of moving to an adult approach to healthcare. The process occurs regardless of whether there's a change in provider or not. The fundamental steps of healthcare transition are planning, transfer, and integration. So today we're going to focus on the transfer and the integration piece. The goal of healthcare transition is the same, regardless of that young person's medical complexity or their potential, meaning their developmental or intellectual ability. Certainly the intensity by which the steps to healthcare transition are experienced may depend on the medical complexity and the presence of an intellectual or developmental disability. There are 2 main goals to healthcare transition. The first goal is for the young person to develop skills and their abilities to manage their own health to the best of their own ability. Then the second goal is for that young person to effectively use healthcare services. So there are goals on the provider practice side as well. And the provider or practice really should work to ensure that there's that organized process, both on the pediatric and on the adult side, to facilitate and support planning, transfer, and integration. Okay. I am not going to go through all these 6 core elements. I know in previous presentations, this was reviewed in detail. This is just to remind folks about the 6 core elements and know that the 6 core elements clearly call out and they define the basic components of a structured transition process, both on the pediatric side and the adult side. So you can read clearly under each core element, the provider or practice task, which needs to be accomplished for each of the core elements. So this right here, when I was preparing this talk, I was looking for images of of bridges. And I purposely didn't pick one with a bridge of like a wooden bridge or a rope bridge, but look for a bridge that was concrete and steel, really representing a bridge that was strong and enduring, if you will. And I want to share with you my experience in healthcare transition, focusing on the transfer and the integration, and really share a lesson that I've learned from this process in being intentional and developing processes that are intentional and enduring, because time passes, people change, circumstances change, and by working to operationalize these 6 core elements, it will endure. So that would be the purpose of this slide. I'm going to start with my experience with the 3rd core element, or the transition readiness assessment. So a transition readiness assessment is a tool used to assist the youth healthcare transition readiness skills. So a transition readiness assessment, it is helpful to begin engaging the youth and the caregiver to begin thinking about and planning and working towards that young person developing skills necessary to that they'll need into adulthood. Once that transition readiness assessment is complete, so areas of relative weaknesses can be identified, and opportunities or can be identified, and you can begin to make a health plan to build up those skills. And then specific information and resources can be provided based on those identified needs. So I don't believe in reinventing the wheel. So at Henry Ford Health System, where I am working, it is a large integrated health system. And in selecting our transition readiness assessment, we opted for the transition readiness assessment that was already available to us through Got Transition. For those who may not be familiar with Got Transition, it is a 25-question screener. It includes 9 questions around the patient knowing how well they know their own health. There's 14 questions regarding the patient's ability to understand how to use healthcare, and there are 2 motivational questions embedded in there. So we decided to use that existing transition readiness assessment. We had the tool. The larger challenge posed to us was how to develop a process which would support consistent and enduring use across a large health system. So in doing so, we established a process that was first automatic, one that had reminders built in, and then one with accountability. So in our health system, patients between the ages of 12 and 21 who are scheduled for a visit type reflecting an annual well visit, they automatically receive a transition readiness assessment at least 7 days prior to their scheduled visit via their patient portal. And we use MyChart. So they're going to get this transition readiness assessment in their MyChart 7 days prior to the scheduled visit. Then the transition readiness assessment, it is sent to that patient population, those 12 to 21, at 3 points in time. At one time in early, one time in middle, and then one time in late adolescence. So one young person, assuming they're with us from 12 through 21, should receive 3 transition readiness assessment at a minimum. So this is what it would look like in that young person's MyChart. Once they open the MyChart, they will get a notice telling them that they have a message, a questionnaire that needs to be completed. They'd click on it, and ideally, they would complete their readiness assessment. So on the day of the appointment, when the provider opens the youth encounter in the electronic medical record, and in our case, we use Epic, the completed transition readiness assessment is available for review. So the completed transition readiness assessment is located in the questionnaire section in Epic. If you're familiar with Got Transition's transition readiness assessment, you'll note that there isn't a score associated with this screener. We did add a score, and we assigned a point, a numerical value. So you get 2 points that are assigned for every time the response is, yes, I know this. You'll get 1 point for every time it's I need to learn as a response, and then 0 points if the response is someone needs to do this. So the sum of all those responses is provided automatically in Epic. And this image to the left just kind of depicts that sum score for this particular youth. But do know there isn't a pass, fail, there isn't a cutoff assigned. Really, that score allows the provider to really look at the progression over time of that young person's health knowledge and health skills. The image on the right is what the medical assistant or even the provider would note. They would see if by chance that young person didn't complete their transition readiness assessment. So what we ended up doing was modifying the workflow, the rooming workflow for our medical assistant, so that if they see that the transition readiness assessment was not completed, they have specific tasks to do. So what they would do is they would room the patient, they would open up the screener, and the patient would either complete it on the exam desktop, or they'd encourage the young person to pull out their own device and complete it on their own device. If for whatever reason the screener wasn't assigned, the medical assistant could then assign it at that point in time. So the next automated process to support our transition readiness assessment implementation includes the use of express lanes. So for those that aren't familiar with express lanes, an express lane it's a feature in Epic that puts the tools that the provider needs to complete a specific visit into one single screen. That's what you see here off to the left. So it's a way to simplify and speed up the workflow of the provider. So in this instance, we created express lanes for all age-based well child visits. The express lane template is generated with the chief complaint of well visit. So then for pediatric well child express lanes, they're automatically populated with a templated note based on age, age-specific pre-ordered labs and vaccines. The level of service is automatically identified, and then age-specific anticipatory guidance. So the completed transition readiness assessment is pulled into that templated note. The provider doesn't have to do anything. It automatically populates the note. Then they're under the assessment and plan, it's automatically populated with an interpretation or a plan around the transition readiness assessment. So the image to the right is just a snapshot of that plan section of that templated note. And under the development/routine screening, you'll see that there's the health skills questionnaire. The provider, when going through and documenting in their note, they would select that. If you know Epic, you F2 through everything, and then we click forward, you get some options. And these are the options that you can select from, noticing that there is a free text for if your option isn't available. But it's a way to really simplify the documentation around the transition readiness assessment. And like with anything in a note, communicates to that next provider or even the same provider, the clinical team, what work is done around healthcare transition. The image to the right, I really just tried to pull images so you can visualize it. It's easier than just describing it. But the image to the right just depicts what that completed note looks like based on what was selected, what was done for this particular young person. So this is the last automatic piece of the express lane. And this is just an example of the information that's automatically placed under the patient instruction section in Epic. So they're going to get age-specific anticipatory guidance, but we made sure there were age-specific anticipatory guidance and information for early, middle, and late adolescents. And that's automatically sent in the after visit summary, hopefully to reinforce what was discussed in the clinic, and then is sent to the patient via their MyChart. This is a process around alerting. So should a patient come in And it doesn't have to be for their well child visit, but you can see that if that young person is due or has missed completing their health skills questionnaire, we included the transition readiness assessment as a health maintenance topic. So this tells you that the cadence that this screener is given every 3 years. For this particular example, the patient received it in 2018. The date all the way to the left tells you when it is due. So providers, when you're seeing a patient for any reason, you'll be able to identify overdue immunizations, blood work, and then the transition readiness assessment, assuring that another way that these transition readiness assessments are completed during adolescence. So this is the accountability. So we created a pediatric screening dashboard, which houses completion rates over whatever specific time we want to identify, but it looks at the completion rates of all of our screeners, including the transition readiness assessment. So this will house, regardless of what department the young person is seen, throughout our entire health system. So internal medicine, family medicine, pediatrics. If that young person is seen and has completed their transition readiness assessment, the data is captured here. So what I'm able to do is I'm able to look at completion rates by provider, by individual clinic, and by department. I can stratify by race and gender. So it's a wonderful way to get a sense of like who's doing a wonderful job with their transition readiness assessments, where are their opportunities, and it can certainly drive kind of like quality improvement processes. Providers have access to it, and some are more motivated than others to beat their colleague, but it's a wonderful way of accountability. So I did spend quite a bit of time talking about the transition readiness assessment and how we implemented the tool to be enduring. I want to now shift and talk about our process specifically around the transfer and integration that we piloted over some time. And we called this pilot a meet and greet. And so you'll see how we utilize the transition readiness assessment within our pilot. So this meet and greet really captures the time of that very last pediatric appointment through that first adult primary care visit. And in our instances, it was internal medicine. So we identified very specific roles that we wanted to occur at 3 points in time. The first point in time is that last pediatric visit. That last pediatric visit, the provider will review the most recent transition readiness assessment. I'll identify opportunities and needs and provide information and resource to the youth and the parent. During that last visit, we're also making sure to identify an adult provider. And that process really looks like we had pictures of all the adult providers that were in the practice that we were referring our young folks to. And we took time to kind of go through those pictures, describing the providers, but definitely eliciting from the young person their priorities and adult providers. Some young folks may have had priorities around gender of the new provider. Some young people may have preference about race or age, or even that adult provider's comfort with regard to their diagnosis. So it's having that conversation together, identifying a provider that would be a goodness of fit. Additional things at that last visit we're assuring that we're doing is passing on a document that we created called Tips for that Young Adult Transitioning from Pediatric to an Adult Provider. That's given in the after visit summary. So we review that in clinic, but they have it also in print. Really looking at ways of making this enduring by as opposed to picking up the phone or giving a telephone number to the patient, we started using Epic and leveraging the internal referral through Epic, but we identified that this visit is not a typical adult visit, but a meet and greet visit. And this was important because it was then distinguished in the internal medicine work or in their work queue. So they knew what type of appointment to schedule for. We had Epic.
Just a 4-minute warning.
4-minute warning. Okay, I will hurry. We had an express lane documentation around the visit to make it simple. And then most importantly, we made sure we had that young person's contact information in Epic. That second point in time is called a bridge. What we identified is we needed all the activities in the bridge to happen within 1 to 2 days of that last pediatric visit. And it was a nurse on the internal medicine side that would work that work queue, identify that patient that is being referred for a meet and greet visit. They would call the patient, schedule a meet and greet appointment, text message and my chart message, an appointment reminder, and then send out a few things via my chart, a welcome statement from internal medicine, a picture of the provider with a link it was linked to a video introduction of that provider. And again, they would send on that tips for young adults transitioning from pediatric care. And that brings us to that first visit. What's key is this first visit was conducted by a nurse, not a physician. And the nurse drove this visit by providing an orientation of reviewing the care team and their roles, providing the health care transition policy to that young person, reviewing it with them, reviewing their latest transition readiness assessment again, identifying weaknesses and opportunities and giving resources, would review health status, medications, allergies, just a wonderful review. But more importantly, at the end of the visit, that new provider would come in, introduce him or herself, and acknowledge that they were a new patient and welcome them. That provider then sent a staff message to kind of close that communication loop back to the pediatrician. I think I have one last slide. Yeah, this is, so I really am proud of the work that we've completed here, knowing there's a lot of work still to do. And I detailed these accomplishments, but I will acknowledge that there's still work to do and changes so that we can achieve health equity for all of our patients. And the resources that I sent out to you, I recognize specifically the transition readiness assessment, since I spent so much time talking about it. We hadn't taken into consideration the literacy of all of our patients, and consider, might that be the reason not all the health skills questionnaires or the transition readiness assessments were completed. So we're right now in the process of uploading all of our screeners, including our transition readiness assessment, onto iPads using a different platform. So when the patient comes in, if they've not completed it, it can be done on the iPad, and the iPad will read the screener to the patient. So that can be done in privacy, being read to them, not having to worry about their literacy level. The same thing for English. If English is not the primary language, we're working to translate our translation, or the readiness assessment, in Spanish and in Arabic to start. We recognize this assessment is not appropriate for all of our patients, especially those with intellectual and developmental disabilities. So we're working to integrate a readiness assessment specifically for this population, and really working with IT on that decision tree as to who gets which of the transition readiness assessment. And we'll have that as well translated in different languages. We know that, insurance or payer alternatives is definitely a barrier. Unfortunately, on the pediatric side, the insurance that accepted on Medicaid is different in some instances on the adult side, and this has been a barrier. It's definitely outside of my pay grade to make affect that change, but I'm certainly calling attention to it to the powers that be so that we can definitely do better. In our health system, we definitely have had a limited number of providers of color, and that has deemed to be a barrier for many of our families have been vocal about that, as well as providers with limited skills and knowledge, experiencing and caring for those with intellectual and developmental disabilities. So I just wanted to call out that this is the process we've done. We know there's still work to improve on that process so that everyone can, benefit from the changes we've made to improve our healthcare transition and integration. This is pretty much it. I just wanted you to keep these patients in mind. So might you have specific questions about this process and wondering how might their care, would be changed by implementing this process. But I'm open for feedback or questions if you have any for me.
Wow, Tisa, so impressive. Totally fangirling here in terms of all of the things you have accomplished in your health system. There are several questions in the chat. A big one is around how much of this was pre-built, or was this something that your organization, from an IS standpoint, it's all internally built?
None of it was pre-built. It was all, and it was really all driven from the desire to, improve what we're doing here, and with patients' guidance and really supporting and helping our health system learn about healthcare transition. With any of the tools, it really was like paper and pencil. But again, how can it be enduring and generalizable across departments outside of a pilot? So that was partly, well, that is the reason this has taken so many years. It takes a long time for IT to get anything done, unfortunately.
Yes. And then how did you get buy-in from your adult counterparts, your internal medicine colleagues?
I think at least for me, the buy-in was really very organic. It was providers that I was referring my young people to, and I have a large number of young people with special healthcare needs in my practice. And so it was organic by finding some providers that were interested, were willing to learn and to take on my patients. And we recognizing that while that may be our interest and our desire, we needed a structured approach. So really pulling in those folks that had the everyday lived experience of the difficulties and the barriers of transitioning young people into adult medicine. It really was a lot of networking, a lot of connection, connecting with adult providers and just finding those that have an interest. And I think when we came together as a team, working together and incrementally to move the process forward.
Awesome. And then there was a question about billing that meet and greet appointment. How does that work if it's mostly a nurse with a pop-in with the provider?
Right. And so for our pilot, and when I talked about things changing, processing people, we've had some process changes, and the pilot, this meet and greet, is still enduring. And internal medicine, they are not billing for that nurse appointment. What we're attempting to do is to switch this meet and greet virtually and looking at codes that we can use for that virtual meet and greet. I know on the adult side, because they really have liked the meet and greet, it's been very satisfying for the providers. So they're looking at codes, virtual codes that they can bill for the meet and greet.
Wonderful. Well, I know there are several other kind of shorter questions in the chat around some of the logistics. So I'm hoping you might be able to take a moment to answer those so we can move on to our case and keep today's session rolling, because our case is very related to this work. So I want to welcome Alicia Henriksen. She's a nurse care manager at Gillette Children's to introduce our case. And this will be moderated by Wendy Berghorst, who is from the Minnesota Department of Health. Thank you.
Can everyone hear me okay? Awesome. All right, so this is a patient that I worked directly with. So just giving you guys a little bit of heads up on what the case is about. So this is a 26-year-old patient. He has a rare chromosomal abnormality, which makes him very complex, and has historically gotten inpatient and acute medical care at Gillette Children's. And so mom called in about 1 week after the patient's 26th birthday, and the patient was exhibiting some respiratory, possible UTI symptoms, increased seizures, and she was hoping to get an appointment with our acute same-day clinic, which we call our quick care clinic. I don't know, can I move this, Tori, or do you have to? Oh, there we go. Okay. So at Gillette, at the 26th birthday, given that we're a pediatric hospital, the option for acute same-day clinic and inpatient admission for acute illness is no longer possible. So that cutoff is age 26 at Gillette. Mother was under the impression that it was okay at 26, but the cutoff was at 27. So there was just a little bit of confusion there. And she was very frustrated that she couldn't be seen, despite the fact that she had, previously gotten seen for this stuff at Gillette. and he could continue to get his non-acute outpatient clinical care at Gillette long-term. So he still sees a lot of our outpatient providers at Gillette, but just could no longer get that acute care and inpatient admission care at Gillette now that he turned 26. He was ultimately able to get a same-day appointment with his primary care provider. However, mom did state that that is not typical, that she's not able to get in same day with primary care, and that's why she's utilized that in the past. So the big question that we have, or that I have, is how do we start building an acute same-day illness plan that was covered by Gillette in our quick care clinic and is now driven by the primary care provider? And this involves many different facets of what Gillette has offered for this patient in the past, because Gillette does do a lot with feeding intolerance and G-tube difficulties, as well as respiratory symptoms, urinary tract symptoms, seizures, although this patient is seen by another neurologist at a separate clinic, so typically that would be sent over to that neurologist. But there's a kind of a lot of facets that Gillette covers up to age 26 that then would potentially not all be covered by his primary care provider either. So definitely asking to kind of discuss, where do we start when we're building this basic list of like where can you now go now that Gillette is no longer an option for that acute care.
Thank you, Alicia. That's quite a situation, and it's very it'll be great to hear from our group to see what type of thoughts people have. Do we have any questions, first of all, regarding the case? So it's a 26-year-old with rare genetic and obviously was used to using the services at Gillette and found out they couldn't. So it's sort of who was preparing or working with the family is part of that. Or so do we have some questions? Some additional, yeah. Who to call for triage? I think that is a big thing. So does anyone want to, we'll take comments or questions?
I can just clarify a few other things about this case. So we're in a unique spot where our pediatric care goes up to age 26. We do absolutely no primary care at our clinical institution. So everyone should have primary care doctors in place. As we all know, primary care doctors vary in terms of when their age cutoffs are. Some are 18, some are 21, some are 24. But for the most part, most of these patients, by the time 26 hits, should be established with an adult primary care doctor. So as we are kind of thinking about patients aging closer to that 26-year mark, we do have the opportunity to really partner with the adult primary on what is the appropriate same-day plan. And many patients, right, they kind of have a trend of what are the common things that come up acutely. You know, how are you going to address UTIs? How are you going to address feeding intolerance or a G-tube issue? And each primary care clinic has very unique resources in terms of being able to address those same day versus what might not be able to be. At Gillette, we have every G-tube size you can imagine just in the cabinet down the hall. I've never been to a primary care clinic that has G-tubes lying around to put a broken or fix a broken G-tube. So that'd be like, where does that sort of care go? Or another example might be with feeding intolerance and wanting to get electrolytes. Not all primary care clinics can get electrolytes back same day. They might be a send out test and you get them the next day or the day after. So how might we kind of partner or start that process, right, of developing a joint plan of care? Peds has knowledge from history. Adult has knowledge from what's available and what works in the adult world. Any thoughts, or has anyone worked on a similar scenario?
Well, Tori, I keep going back to mom's frustration because just at looking at our internal documentation at Gillette, it's not really even clear to us. Is it at 26, at 27? So other facilities, how do you clearly state when services end?
Peggy?
Yes, I'm wondering, Tori or Alicia, is there a policy that conveys to the patient and family when these changes happen, and do they go out more often when they get closer to that age group? Again, I'm feeling what Rhonda's feeling in terms of the fright of not knowing or not being prepared for that.
There is not currently a patient-facing policy. There is an internal one, but not patient-facing. It's in progress. And certainly that's a piece of the puzzle, right? Like there needs to be forewarning. And I think once that's in place, we can go down that rabbit hole of getting it to them in consistent fashion. Looks like Megan has her hand up.
Megan?
I think that that's part of, I mean, I can guess what happened with that patient. They may have presented to the urgency center that didn't have the resources that the patient needed, and then they ended up in the emergency department where they did have the resources, but probably wasn't the best level of care. And so, you know, we struggle with that and kind of think about how, from a population health lens, that's where I look at it. And from that population health lens, you know, how do we bridge that? Because even in a pediatric clinic, that pediatric clinic may not have had, especially in our rural communities, may not have had those resources either. And so how do we look at that cyclical levels of care to work more diligently together to give the patients the resources that they need at the level of care of which they need? I don't know the answer to that, but it, you know, kind of what appears what the case study is trying to achieve. I can guess what happened with that family and know where we would like to get to long term to allow for that bridging to have the appropriate level of care and the appropriate resources that that patient needs to handle that level of care.
Tisa, is there sharing of care, emergency care plans as part of your process?
So interestingly enough, years ago, I did have a separate care plan with an emergency care plan for my patients with special health care needs. When we moved onto Epic, it was different. We had Care Plus, moved to Epic, and did not get that integrated because the IT folks felt that the information that was already built in Epic kind of, was the answer to the problem, and it really wasn't. And so we've circled the drain with this, saying, you know, update that problem list, use the assessment plan under the problem list. So where I am now is trying to optimize the use of Epic to have an emergency care plan, but it's not optimal. It really isn't. I would love to see something better.
I think developing an emergency care plan allows the people who have developed it to actually send it before they're going to their primary care. They've chosen a new provider, and they can say, I can do this, I can do this, I can't do that. And then this care plan gets translated to the family, saying they often know what the problem is. Sometimes they don't, but these families know these young people very well. And ideally they'll say, okay, if you can't, you've got a problem I see you aren't going to be able to handle. And then you have to develop a plan where they would go. And it might be the emergency room. I mean, that's the way it is. We certainly do this in general pediatrics. You know, you're calling in at night and the family's saying, I have a fever 106. they say, well, we can't handle that in the office in the morning. You've got to go to the ER tonight. And families often know that. But I think the more complex the young person is, the more detailed the plan needs to be, and the chance of having the new primary care provider say, I'm comfortable with this, I'm not comfortable with that, teach me about this. I know I have to send them to ER for that. I'm not answering the rural question that came up, Megan, which is a good one. But I think this careful developing of what might be the emergent issues and checking out what can be done in that adult provider's office. And it may just be a consultation with a pediatric provider that allows them to stay in that office and not have to go to an ER. And then having an if-then scenario. This does create a lot of planning, but with complex kids, that's what this is about, I think.
And patients, I'll echo that. I think in large part for me, like I feel like in my primary care, I spent a lot of time like anticipating, in decision trees, like worst case scenario, if your child has a seizure and, over this amount of time, what do you do? And that's where I've started to leverage Epic's plan. I will problem list. I'll put that in there and use the overview with that plan. Seizures over 5 minutes, do this, then, do this. And then because Epic is used so widely and for kids that aren't seen within Hinton Ford outside, I know I will educate my parents and I'll tell them that's where I'm putting the problem list and the action and the plan and the emergency plan. They've asked their providers when they're at University of Michigan or at Beaumont, can you update that in that problem list? And everybody's Epic looks a little bit different, but I know some of my providers are doing that. So I just kind of use my parents as the ambassador to say, we need one place that we're all going to look for if and when there is an emergency, what can we do? You can't, anticipate everything, but we anticipate the common things are likely to happen given the child's underlying medical diagnosis.
And they can access their written plan through my chart too, get that.
It is, that's right.
So they
under their problem list. That's exactly right. And it's there in their patient portal. That's exactly right.
Yeah. I was wondering, we do have a couple of comments. Let's see here. Yeah. Having a written plan, I think, is really critical as part of this. Do we have some other questions?
I'm wondering just from a trauma-informed care lens. So certainly Alicia and I talked about this case after it happened of like, well, that couldn't have been further from trauma-informed care than we could have provided. So Alyssa, I wonder, like, how do these situations, emergency, acute situation, trying to figure out what to do in the moment, what are some things that we might be able to do in the moment or preemptively, ideally, to try to take some of this trauma out of this care? Because this brings back a lot of experiences for folks.
Absolutely. And I just added into the chat, any way to increase transparency and expectation, be able to address and anticipate what may happen. And a lot of times you may not necessarily know what happens. And I think being transparent about that this might be a difficult situation, that you're going to share along the way what are the steps that you think you can take and what you expect to happen, but also that there might be some kind of disappointment and difficulty and barriers as well. So I think being as open as possible. I think too, allowing, if there's any way to connect and have some kind of like collaboration, support with people who have been through this before, always connecting back to different community and connecting back to people who have experienced some of these barriers before, I think is always helpful. But I think the one thing that stands out to me most in this point from a trauma-informed perspective is communication, making sure it's clear with families, and transparency in as many ways as possible. And just acknowledging that this might be a really difficult scenario until something gets figured out.
Keep thinking of the the finding the right person at the right time for the right care and accessible. So Peggy, go ahead.
Yes, I was wondering, just from an advocacy standpoint, how important a case like this is for a system to see the lack of preparation, the lack of kind of anticipation, and what does that mean for an institution, and obviously what it means for a given child or family. But I don't know from, again, patients or anybody's perspective, if you've used any of these cases to advocate for systems improvement, that you just can't keep going on without being clear, without having an emergency care plan, without having this kind of connectedness to the adult side.
I'm happy to, I can tell you we use these a lot when I'm talking to systems. I think the first time it comes up is when people say, gee whiz, people can't agree on a time when the young person should go to the adult system. In this case, it is 26. It just wasn't clarified that it was when you turn 26, not when you actually turn 27. But the examples, and these are real cases, and sadly, they go to legal problems, and that's what drives some of these systems. You know, you have a young person that has a, let's say an ulcer, and also congenital heart disease, and the cardiologists never want to let their patients go. And the gastroenterologists and the children's hospital say you're out at 18. So here you have this 24-year-old person who does have an adult gastroenterologist, but still is seeing the children's folks, and they get chest pain. And you've left it in that person's or the patient's hands to make a life or death decision here. Because if she goes to the wrong place, let's say she's having a heart attack, children's hospitals are good, but they're not as good as adult hospitals to take care of a myocardial infarction fast. Or if she's having a bleed from her ulcer. So, I think that leaving it in the hands of the patient is inappropriate. And so often these scenarios do drive systems to say, oh my gosh, this is not good quality care. I'm legally at risk. And so I'm always talking about quality and safety and in a system. So use the words that make them stand up and sit up and look at you and go, oh my. And so it's those kinds of things. And sadly, it often has to happen within an individual situation with a very vocal family. And that family will take this all the way to the CEO. And, everybody who's interested in transition is going, yes, yes, yes. And everybody else is saying, oh no, another vocal family. But no, the point here is that you really have to be thoughtful and not leave it up to the patient who doesn't have the level of knowledge they need, and try to have a plan of some sort and be transparent. Tell them what the plan is. If that's the case, then, always you're going to go to whatever. They've got to be able to handle the congenital heart disease if they're going to the adult side. And if they're going to the pediatric side, they're going to have to know how to handle an MI. So they quickly decide, well, we don't do that, so let's partner. So I think that's a really good question, Peggy. But yes, I would say that's one of the most common reasons, other than losing patients within systems. In other words, people who, after they've been, kids have been born, often go to a different pediatrician outside of the current system, or when they go from pediatric adult healthcare, and in these large systems now that are being held accountable for populations, they don't want people to disappear. So that's another reason that gets people to think about this very carefully, sort of two driving things.
I like the dashboards that you also shared to really look at accountability and see what clinics are doing it or what providers. People are very competitive and they want to do well, and they want to be on the same page. And part of it with that meet and greet, I really think that the ability to do that quickly and get that care established. It's like, oh, you don't have to come back for another 6 months, but I think it'd be so much better. Sounds like they can get in sooner and meet the nurse, and that could is probably part of the meet and greet visit, is maybe some of that emergency review.
What I would definitely so, because part of that is right, that health review, right? So if you are someone with a medical, there's going to be more time on that medical review, and it's not just reviewing what medicines you take, but what are the status of your medications? Do you need any refills? How is refills handled? What do you use this medication for? Being very, very explicit, more so than you would with, if you think of just the way the standard of making that first appointment, it's glossed over in many regards. And so the idea here is that it's not just a way to give an orientation, but really to provide information to that young person. I honestly, when I thought of this process and we're working out, constantly refining it, I think it is no different than you're planning to go to college for some kids, right? They have those college tours. You ask the questions, you see the classrooms, you talk to other students so that you feel like, yeah, this is where I can go. I see myself here. And really the same with the meet and greet, that young person needs to say, yeah, I can see myself coming here, asking a question, being heard, and all my care being taken care of. And so that meet and greet would be that time that you would start anticipating what are going to be your needs, not now, but ongoing, and making a plan around it.
Doing it virtually is a wonderful way to handle this, particularly the more complex the young person is, because the family can be on, the nurse from the adult side, the pediatrician is on, and the young person. And there's a scenario in our coding and payment tip sheet on how to bill for that, and also some information up on our website to help families understand what a virtual visit like that would be. And so I encourage people, the real issue there is the coordination, as always, to get everybody on the phone at the same time. But in some systems, it becomes just an available time, and people get slotted in when they have somebody. If they don't, then the time is used and rebooked. But it is hard. That's a big issue for sure.
Well, I wanted to thank everyone for your incredible conversation and participation. And it's so wonderful to hear from so many different perspectives about how we can do this work better. We are excited that our next session will be, again, another journey of how transition is occurring in other places. So in March 4th, we will welcome Chris Hanks from Ohio State University, talking about considerations for adult outpatient practices for working with young adults with intellectual and/or developmental conditions. So really thinking about, from the adult side, how do you integrate that patient? As for today, on the left side of your screen here, you will see our post-activity evaluation. We welcome your feedback. We want to make this a meaningful hour of your work week. So please give us all the feedback you can. And then two, if you're interested in doing what Alicia did today, of talking about a case, again, either can be a patient, it can be your process of, I'm really trying to get this integrated into the EMR. Do people have suggestions of how I can do that? We want to hear about those things too, and to get you meaningful feedback to start implementing stronger transition work in your practice right now. So thank you very much for joining us. Within the next month, we will have our registration for our second annual Minnesota Transition Summit. It is scheduled June 13th. It will be in St. Cloud. There also will be a hybrid virtual option. So regardless of where you are, we would love to have you join the conversation and the learning together. So with no further ado, thank you very much for participating today, and we will see you in March.